Um, Yep, that was the important piece. So our agenda today again is to review the various items that review the rate model components, our survey overview, the cost survey worksheets, the direct care staff types. It's important. We want to make sure that we captured the types of workers and the titles, because we realize there's a lot of difference across the waivers and what people call different workers, as well as then communication and what our next steps will be. We could go to the next slide. So this is just talking about our today's objectives. So we are going to review the various items that go into the rate model. We're going to review the purpose of a provider survey and its main components. We're going to discuss the 2022 Kentucky Cost Survey and get feedback on what we put together thus far. And also we want to get feedback specifically on the direct care staff setting that we've used in the survey. Kelly, can go to the next slide. So this is, of course, our timeline. You've seen this in the first deck. Currently, of course, we're in the March part of the timeline. This month was for development and review of the survey. We're going to release the survey in April and then begin to analyze the data. And we also will analyze other data sources while we're waiting for providers to respond with their submissions. And so at this point, I'm going to turn it over to our subject matter experts with Guidehouse for them to go over the rate model components and the rate survey.
Thanks so much, Pam. Just want to make sure you guys can hear me okay.
Yep, you sound fine.
Yes, we can hear you.
Okay, great. All right, this is Elizabeth Kahn with Guidehouse. I am going to be talking to you about the survey. We'll be going into a ton of detail. I know you've all had a couple of days to review, but we'll spend a lot of time today really looking and diving into that. But quickly, before we get into the survey itself, just to recap the rate model components. I know we talked about this in last month's meeting, but there are a couple of components that are part of the core direct care piece of the rate model. And then similarly on the next slide, a couple of components that are part of the core rate model for non-direct care. And all of these we will be going through in a lot of detail as the months go on. So both direct care and non-direct care, we will be spending time on the different components, the results that we're getting, and we'll talk about all of those with you all to get your feedback on what exact numbers we're going to use in the models for the different services. And again, as we talked about last time, rate models, of course, rely on a variety of sources in order to supplement the survey itself. We want to make sure that the data is reasonable, and we know that there are other important factors beyond just provider reported data, like inflation factors, other state benchmarks, the Bureau of Labor Statistics data. So all of these are going to come into play as we go through the various components. And just generally, we really do understand and recognize how fast things have been changing, and the need to incorporate inflation, especially in circumstances where we might be relying on older information, like older survey data. And so that is something that we are very aware of and we will be incorporating going forward. And that's going to be tailored to each of the components, so that every single piece is as accurate and we're giving the best assumptions of what's going to happen going forward. So we're really trying to incorporate as much of the changes that we know have happened as possible. All right, so I'm going to start with a high-level overview of the survey. And really, before we get into that, we wanted to orient you all to the responses that we received last time. And as a reminder, we did a large-scale provider survey in 2019. And so these are the results of submissions from that survey release, where we got an overall response rate of 30% that represented 55% of all waiver expenditures. So we really had half of the waiver expenditures submitting a survey, and we feel pretty good about these results. As you can see, we had a more significant response rate from larger providers compared to smaller providers. And one thing that we wanted to recognize is that since we are doing this abbreviated survey for this go around, we're hoping that the administrative burden is really quite reduced, and more small providers might feel empowered or encouraged to fill out the survey and respond accordingly. And then just a couple of notes about the 30% response rate is that is pretty typical from what we've seen in other states. And I think that would be around our goal of a response rate for this time. And we also want to note that we are not, I know we really keep beating this drum, but we are not only relying on the survey data. There are other sources. And we understand that some of these surveys can be really tedious and difficult. And so that is just another reason why it's important to support the survey data with data from other sources. And then I guess lastly, we will be providing a number of other technical assistance resources, like reminders, detailed training that we'll talk about later, so that hopefully we can even increase this response rate even further for this go around. So we will be collecting cost and wage data about a variety of services. The survey is interactive, so as providers select which services they provide, other tabs change accordingly, and we will go into that. We will go into that in detail as we walk through the survey itself. And again, I know I just talked about this, but we're really just hoping that providers can fill out as much of the survey as possible. And we have the technical assistance to encourage folks to do that. And we did talk about this last time. Survey completion is not required, but it is strongly encouraged. And we do see your role as the work group to encourage your peers or the groups that you represent to complete the survey so that we do have the most accurate information. So any kind of encouragement that you all can provide for folks to fill out the survey would be really great. All right, so again, we did cover this last time, but this just talks about the abbreviated approach. And this abbreviated approach is just the approach for the survey. So we are still taking into account all of the cost components that we talked about earlier. Again, using a variety of sources, the previously submitted provider survey, inflation factors, BLS data, etc. And our goal here is really to reduce the administrative burden and to determine the rates as quickly as possible, because we understand that providers do need these updated rates. And so we would like to get this done really quite quickly. And so this abbreviated survey approach will help with that. And so these are the topics that are survey will focus on, whereas the other cost components, we will rely on either previously submitted survey data or other data sources like we talked about. And we're really focusing on these particular items just because we know that these are the items where there have been really quite significant changes over the last 3 years. So wages in particular and benefits, and then supervisor wages and benefits as well. And then other, in this case, we're really talking about pandemic costs, and we'll get into that in just a moment. The worksheets that we have in the survey are listed here. I'm not going to go into them right now because we're going to go into the survey itself. I'm going to pull that up. But I do just want to note that the tabs that we have developed really do align with the direct and non-direct care components that we described earlier. And so again, just a reminder that this is just a subset of what's going to be used to develop the rates, but it's an important subset because we do understand how impactful changes to wages and benefits have been, and we really want to be able to capture those more recent changes based on provider feedback. So with that being said, I'm going to turn to the presentation itself. We'll go through each worksheet, or the survey itself, excuse me. We'll go through each worksheet. And one thing that I want to note is that we are requesting written comments from you all back by Thursday, end of day, so March 31st, end of day. Obviously, we're going to spend a lot of time right now discussing. I would love for this to be an open dialogue where we can collect feedback, but we do know that while you have had a week to review the survey and the instructions and reflect on any feedback that you might have, new things might come up as we go over this, as well as over the next couple of days. And so any comments that you have, we are requesting in written form by end of day, March 31st. And again, just emphasizing that it's really important to us that we capture those comments, and that is why we're asking for them this way, so that we can make sure that any feedback you all have, we're able to accommodate it. And just to help guide the conversation as we're going through the survey, and we'll come back to this after I open that up, but as we're going through it, the kinds of things we'd like your feedback on are what parts of the survey might be really difficult to complete for providers, and what are ways that we can improve that. What terms or phrasing are not clear and might be answered in different ways if people interpret it differently. Are the service category groupings intuitive? And we'll talk about that in a lot of detail. And then the COVID-19 question. So how can we ensure that they really appropriately capture the pandemic experience? So those are the things we kind of want you to keep in the back of your head as we go through the survey. So I'm going to share my screen with the survey. Sorry, I think that was me. Okay. What? Sorry. Just trying to find where it is on my screen. Okay, can you all see, could somebody confirm that they see the Excel file that I'm sharing?
Yes, we see it.
Thank you. Okay. So, all right. So here we have just the cover sheet It really orients folks to what they're looking at and just provides a link to the website and to our email address. And one of the nice things is that when you click on this link, an email will come up with an already populated email. The email address will be populated and the subject line will be populated as well that says question about the rate study. So we're trying to make this as easy as possible for folks and really make it, as straightforward as we can. Okay, the contact info slide. Again, we're just asking for basic information about the agency. We're asking for a provider name, a contact name and title, a phone number, email address, city, zip code, and agency type. An agency type is for-profit or nonprofit, and there's just those two to choose from. And we've also added some data validation throughout. So for example, if somebody were to enter a 6-digit phone number instead of a 10-digit phone number, they would get an error. So I can show you. It says, please type in the 10 digits. So we have a couple of those things throughout, which we think will help providers make sure that there's just not like an accidental error or anything like that. And that just helps make it a little bit straightforward. And then we're looking for the agency IDs. So these would be any IDs belonging to the agency that's filling it out. And again, we do have the accompanying instructions that go with this document where all of these things are explained in a lot of detail. Okay, so moving on to the service area, we're really just looking for which counties are serviced by the organization. This just has a list of all the counties and a yes, no. So you check yes and it switches to green, and it's pretty straightforward, where we just have counties and a yes, no, whether that county is served by the agency. I'm seeing a question in the chat. Should this information be the person that completes the survey if it is someone that is other than the executive director? Yeah, I think we understand that some of this information is pretty detailed, and in some cases there might be multiple folks, or maybe a financial person is the best person to complete the survey. And I think we are looking for the person completing the survey, so that way if we have questions or we think that something might not be filled out correctly, I think you're talking about the contact information. The contact information, we're looking for the contact information of the person that would really be best to go to if we have questions about any information that's in the that's filled out in the survey. And then I'm also seeing, I would clarify the service area, counties authorized to serve in or counties serviced by that provider. So I guess, Amy, are you saying that sometimes there are counties where somebody is authorized to serve, a provider is authorized to serve, but then they don't actually provide services there?
Yes, I mean, a lot of times providers are authorized to serve in a huge amount of counties, but they don't actually serve in those counties at the time. So I think you just have to go in with the understanding that if someone's authorized to provide services in a county, they may not necessarily be currently providing a service in that county.
Yes, absolutely. And I think we would want where they are actually providing services, as opposed to authorized. But we will definitely clarify that, because that's a really great point. I don't want providers filling this out where they're authorized, and then we'll have a ton of counties listed where they're really only providing services in a few counties. So we can definitely clarify that both here at the top and then in the instructions as well.
I have a question. So is it better for my agency to complete this as 6 different agencies, since we have 6 provider numbers in various locations in the state? Or is it okay to roll it up and just list my provider numbers that we have? I mean, are you wanting to look at some regional differences?
I think it would be okay to fill it out as one rolled up, just listing all of the provider numbers that you're covering here. Make sure that you include all of them, and then include all of the service areas covered by each of those provider numbers. And I think that we may do some breakdowns to help shed some light on some regional differences later in the process, but that's not necessarily going to, or I don't think as of right now we're planning to do any kind of like regional specific rates.
Okay.
Yeah. So I think it would be probably easier for you all to just fill out one survey for one. If it's one agency that kind of operates 6 different providers, I would recommend that there would just be one survey.
Okay.
Okay, so any other questions before I move on? I don't want to cut anyone off. I think this has been great questions and feedback so far. Okay. So then we get into this services provided tab. So this is all services covered by the waivers that are included in the rate study. And again, it's just a yes, no. And similarly to what we saw in the service area tab, it will turn green if you select yes. And this is interactive. So I'm going to show you in the next couple of tabs how this works. But when you select yes here, it will impact the options that a provider has available on the other tabs. So this is going to be a key tab to make sure that it's accurate. And so we just have all of the services here with a yes, no, and we do have a list of services that providers might offer but are not currently included in the rate study. And these are the ones that we talked about last time. Okay.
I have a question. I think in the services offering or under COVID someplace, I think we need to find a way to account for people who have closed, either permanently or temporarily closed a service or down altogether. And obviously DMS would have the information of providers who have completely gone out of business. But I think a lot of services aren't going to open back up. And I think that that's an important access issue that will affect the outcome of the rate study.
Yeah, absolutely. I think that's a great point and a great addition. I think that's something I'd love to explore in more detail when we get to this additional questions tab, which is really focused on the pandemic. I think that could be a really great place to add that in specifically. I don't want to jump too far ahead, but I think that could be something where we ask, have you had to discontinue any service offerings due to the pandemic, and we could ask some questions on this tab to go along with the other COVID related questions. That's kind of my immediate thoughts there.
And just something else, I would also make the same note about the services authorized to provide versus services actually provided. Some providers are authorized to provide certain services and don't.
Okay. And we will definitely make that update here as well. Okay. So going to the benefits tab, this is where we start getting into what I would say is the meat and potatoes of the survey. So this is focused on benefits for direct service staff. This information on the top will carry over from prior tabs, from the contact info tab, so there will not be any, you won't have to fill this in again. Only the gray cells will need to be filled in. So how many employees provide direct services to clients? And we're looking for full-time and part-time. And I guess I should mention, in the instructions, we have a great definition of full-time and part-time. We encourage agencies, if they already have a definition of full-time and part-time that they use to determine who qualifies for benefits, then we recommend they rely on their own definition that they already use. But if they don't, we define it as 30 hours or above is full-time, and 29 hours and below would be part-time. And we'll definitely continue to provide, sorry, I'm seeing the question in the chat, which is how are we accounting for important staff that don't provide direct care? So we definitely understand and agree with the fact that there are many, many important staff that do not provide direct care. We have decided to rely on the prior survey for this information. We have quite a bit of information on these types of staff. And we will supplement that data with the Bureau of Labor Statistics data, inflation, as well as some of the other data sources that we have talked about. So that is one really key example where those other data sources will come in, because we definitely recognize the importance of other staff who are not necessarily providing direct care, but who do keep the doors of these agencies open.
So is there anywhere we're going to capture kind of open positions for the DSPs? I think I have about 150 direct support professional positions open across Kentucky. And obviously that does influence cost and things like that. In a lot of ways, I'm not paying as much holiday pay, but I'm paying, that premium pay somewhere else. And I didn't see any place where we were going to look at anything like that, or is there a need to look at anything like that?
Yeah, that's a good point. I don't know if we ask, well, we do not ask specifically about the number of open positions, but we do have a number of questions dedicated to supplemental pay, like what you're referencing. I would definitely be open if folks think that that's a question that would be helpful to answer, or if there's other ways in which that those open positions show up financially. we definitely want to make sure that we account for that. So we can definitely answer we can definitely add a question that says how many open positions for direct care do you currently have?
Yeah, and I just saw Amy's question, and I would, and there's another part of this where you ask about the percentage. Not my question, when I get to that tab is what's providing the direct care, but I actually have program directors that are providing direct care, they're working in houses. So how are we capturing all of that in this if they don't traditionally fall under direct care as the leader of a program, but in reality, they are providing direct care. And that would go for a lot of my people, my biller. I mean, anybody in a program might be working in a direct care position at this given time.
Yeah, I completely agree. The lines are really blurry right now between who's the direct care staff, who's in management. I think it's all hands on deck and everybody's just doing everything they can.
Yeah, absolutely. And we definitely understand that there's not necessarily like a clear delineation. So
yeah, and Liz, I'll just speak up a little bit. I think it's important to note that we understand the impact the pandemic is having, and I think that's where we're capturing at least some of the overtime costs and other aspects of it. But unless your executive director and management staff generally provide direct care to individuals, then that's the data that's captured from the previous surveys, where we have all the different program support staff, executive director, it might be a coordinator who schedules transportation, whatever it might be. Now, if they do deliver on an annual basis, on a regular basis, direct services, your executive director carries a caseload, for example, outside of the context of a pandemic, then you would add them as a direct care staff, and we may have to add some options to do an other, and you can name who that individual is, and you can put what their caseloads are and how much their time's allocated to it.
But again, what's the definition of direct care here? I mean, scheduling someone's medical appointments is a component of care that directly affects the person. So, I mean, I think we really need to nail down what the definition of direct care is.
yeah, absolutely. And that is something that we would like to discuss with the group, and maybe I'll jump to the direct service staff.
One of the things
tab.
is too, I think some of that is going to be based on right now what the service definitions are. So what's included in the types of services that are being provided. I think we can look to those definitions as well.
I think that's generally a good tool, but I think one of the primary complaints of the previous iteration of this rate study was that a lot of the care components that are required and necessary that aren't explicitly outlined in regulation, but are still necessary for the operation of a provider agency, weren't necessarily accounted for or included. And I think that that's another big concern moving forward. So I think that's why we need to just take a hard look at this definition of direct care that may sometimes lead out, may not necessarily be outlined in regulation.
Well, I just want to.
Yeah, and Amy, I mean, could you give like an example of what you're referring to? So we have let's say it's a personal care attendant who needs to go out to the home. That would be a direct care staff description. What other aspects are you talking about that's involved in delivering that service that might need to be captured somewhere else?
Well, I mean, I think that there's a lot that goes into running an agency, particularly a residential agency, that is beyond the direct support professional that's in the house that directly impacts the participant's life, that they are actively involved in the participant's life, but may not necessarily be in the home that day. And I'm not necessarily talking about management, even though management is providing direct care right now. I'm just saying generally, this was a chief complaint, you know, the unfunded mandates, the ERE factor, you know, things like that were one of the chief complaints of the previous iteration of this rate study, particularly as it relates to case management and residential. And I just don't want us to fall down that hole again by, you know, failing to consider the reality of what it is to provide these services.
Yeah. So, we can go back and look at the previous survey, because I know the previous survey included a lot of that information. The one concern I have is would the providers be able to capture all that extra time in a quantitative way, right? It's easy qualitatively to talk about the extra effort that goes into running residential services. They're very complex surveys that can be done to capture that. But my understanding was that many of the providers didn't have the capabilities to report all those unique costs that they had. So, and I'll just tell you how we generally handle that. Is once we identify the direct care costs to deliver that direct service, we know just based on, you know, the previous study that was done, as well as a lot of other studies done, that there's a percentage of the cost that's uncaptured, right, in the direct care that's associated with delivering that service. So and there's some statistical ways that we do it. We enhance that direct care cost to cover the administrative costs. Does that make sense?
Yeah. I just, again, would caution us not to fall down the same hole as we have done before.
And I'll also add that just because we're not asking about something in the survey does not mean that we're not including it in the rates. Like I'd like for the work group I'd like to challenge us to think about how those things are different. There is a lot that we can incorporate in our rate development and that we plan to incorporate in the rate development. But we don't necessarily need to like burden the providers with filling out a lot of detailed information that we may already have, and that we won't end up relying on. So I completely agree. I completely agree with you, Amy, that those staff are key professionals, and they really are providing important components of care. But that does not mean that they're direct service staff in this case, and that they're that they need to be included in the survey itself.
This is Steve Shannon. I guess my question would be, is that information captured somewhere? I mean, I understand the percent method, but you know, I think what happened last time, people didn't feel confident in what the end product was. And that creates a lot of confusion and dissension and lack of support for the final product. And I think what we want to do is not have that error again. We want to all feel confident in the final product. Otherwise, there's going to be concerns expressed, and that's, I think, part of what happened previously. And that's the concern I think you're hearing, is that the experience was people didn't feel that all those additional costs were captured somewhere. And therefore it ended up, you know, where are those? And did the final product, the final rate, really reflect what people were experiencing?
Understood. And I think we recognize that we don't want to you know, have the same feedback as last time. And if that's how folks felt last time, then we understand that.
Steve, from the previous survey, do you have any examples of the areas that weren't captured?
People didn't necessarily feel good about the vacant position piece. I think that's an ongoing challenge. And was that adequately captured was one thing I heard about. And those other services that just take place within an organization that, you know, we all count as admin, but we don't really, I mean, people are doing the work, I think is what Amy talked about earlier. And I think Amy just said case management. People really felt confused about what's included or not included. And that's, you know, that's kind of what I heard back to the product that was generated in 2019 is, are those things people do that may not be direct service, are they captured? Are the vacant positions captured? And is that number sufficient to really fully staff the organization? And those are all costs that get built in that people are filling in, you know, just making people, you know, case manager may be picking up time in homes or, you know, the accountant may be picking up time at home. And people didn't feel good about how that was included previously.
Yeah.
Also didn't feel good about the distribution across, and I tried to get the data to figure out how some rates were calculated so I could do the math. And we got a final product. We didn't get math, right? And there maybe not many people want to see the math, but one of my concerns was I saw a number, you know, very long explanation, but I never saw the math that resulted in that number. And that's I think the frustration that I heard from other people. How do we get to these places, and what does it look like?
So and I don't want to spend a whole lot of time on explaining some of the pieces that maybe weren't very well explained last time, but I know one area that caused people some concern was the productivity factor, and that sounds terrible, right? Productivity factor. But I know generally speaking, when we do rate studies, that productivity factor is that amount of time that's not spent on the individual providing direct care, but all the other pieces that are associated with it, right? So entering your case notes, and that could be the making arrangements for a doctor's visit or appointment. And maybe it wasn't explained well enough that that's where that was captured, or would it, or is what you would have preferred to see is a line item of every activity, and using case management, for example, that a case manager might do, and how much time is spent on each one of those lines?
I think that would be helpful. I think, you know, again, I represent 11 CMHCs that provide array of waiver services. But if there's a sampling of that, so we have some idea, or these are the things that we know case managers do, but they aren't necessarily with the individual. I think there's a sense that those services weren't really captured or put into the formula, and you ended up wondering, you know, how is this all going to take place?
Mm-hmm.
Is that fair, Amy?
Yeah, I completely agree with you, Steve. I think just specifically on the case management piece, right? Case managers are they bill a rate for one, I'm just using SCL as an example, for a 1 hour unit of service per month. But the work that actually goes into case management, which I know that many of you,
let me correct you. It's not for a 1 hour unit. It's for the entire month. Not justifying the rate, not saying it doesn't need to be adjusted, but case management is reflective of the entire month of what. So, I mean, it may be that we get notes that list out, 15 different contacts, or have, multiple things that they are doing. So it's not just for that 1 hour contact. It's for entirety what they are doing, which may not even have the participant on the phone with them. And it may be reaching out other contacts. It may be talking to other providers, their family. So, again, not commenting on the rate and its adequacy, but just to clarify that it's not a 1 hour. It's not just for 1 hour.
I just jump in on what Steve said, though, about the numbers behind the rates that were thrown out the last time. my understanding is this is part of a rate methodology that CMS wants us to determine, wants the state of Kentucky to determine the method that how they build their rates. And I'm hoping that, again, there's some transparency in how they do that, with that, including that inflation factor and things like that. I mean, as my agency, I build my rates every year for my budget. And I know exactly what factors go into how I'm going to, project the revenues for my company. And I would think Kentucky would want the same thing. And again, I'm hoping that we get some transparency on how that methodology is created, because that, as Steve said, it's very frustrating last time around. And I know we had to be budget neutral, but it's still very frustrating when it just seemed like, there wasn't a methodology behind the raise, that they just simply reshuffled the dollars we had, and this is what you got. So this time around, I'm hoping there truly is a methodology about how these rates are determined, and that we're transparent with the providers on some level of how we build those rates. So,
and just to quickly respond to that, we definitely have transparency as a goal for this time around, and CMS will definitely require some level of detail in the 1915C waiver rate methodology, and that is also the purpose of this work group. So we'll go through each rate component, how it's calculated, how we get to a variety of numbers, and of course, everything is ultimately DMS's decision, but getting the feedback on each component from this work group, because some of this can be really, really technical, right? So explaining what goes into those technical components, and then at the end, with whatever decisions are made, allowing everyone to see what's available for the CMS submission to get to that rate buildup, it is definitely something that will be available, and it's actually required to be available for public comment.
Yeah. So let me ask, so we know that case management, as I hear the discussion, we may want to take a slightly different approach to that one just because of all the different aspects that's involved in it. What about for the other services, the direct care components? Are there other concerns around that, or is it really just case management that's the big issue?
I think it's other, I think it's goes back to that definition of a direct support professional. And when I'm looking at the page that is up on the screen right now, I'm questioning who do I put on this list. I also question allocation case management on that list. But, again, I have a case manager in all my programs. It's not required of me to have that case manager, but we can't function without somebody that does those tasks of working with the external case manager, setting up meetings, following up with doctor's appointments, talking to the patient when they have something going wrong. So it's not a funded position that I have, but they provide a lot of direct support.
Yeah, is their title also called case manager within your agency, or do they have a different title, or is it just somebody who, we used to use the term when I was at the state, other duties as assigned, that does it?
No, I have an actual title case manager in my agency, but from my understanding, they wouldn't fall under this direct service staff salary and benefits cost, because they're, again, depending on what the definition of what a direct support professional is, but they do provide an awful lot of support for that participant in our program.
Yeah.
And, trust me, they get calls days and nights.
Mm-hmm. So Liz, show the drop down just to kind of have a starting point where folks can see the different pieces that we have, and you might have to zoom in on that.
Well, it looks like maybe Jay on that one to capture if there's an internal person that is working, essentially doing case management activities. Could we quantify a case manager, have an internal and external, or an internal?
That's what I was wondering.
Something. Yeah.
Because I don't believe, David, correct me if I'm wrong, but list doesn't change based on the type of service the person provides, right?
No, this list does not change.
Okay, so if you're just a personal care agency or whatever it might be, and you're not expected to have a case manager, you can still add a case manager line here.
Mhm.
And then we capture whether that person's a supervisor or not,
Mhm.
how many individuals you have. So scroll over, let's look at it. Overtime wages, bonuses, and then
Yeah, those
So-
last,
if we had different waivers on here, would show you'd be able to illustrate how much each of the time spent on each one of the waivers, right?
Yeah, so I can quickly kind of like explain how this is supposed
Yeah,
to work.
let's
So,
do that and then start the discussion up again.
yeah, I think that would be helpful just to orient us. So let's say that, you know, you've selected, you work on these 3 services. I'm just selecting a couple at random: case management on ABI, and then case management on ABI LTC. And I guess just community living supports, just because I selected
But go back to that. Take off case management though, because I want to see how it works first for an agency that just provides direct care.
Okay. It
And then
works. It doesn't matter. It doesn't.
Yeah.
The point is that it doesn't matter what services you provide. Like if you provide counseling across ABI and ABI LTC, you'll go over here and you'll see that now those are the ones that have showed up. So you might go over here. I'll zoom in a little bit. You go over here and you select a type of professional. So in this case, it might be a psychologist. Maybe you employ a couple of psychologists, they're not supervisors, and you actually employ 3 of them. So we would enter 3 here. We would add up the total number of just standard hours, regular hours that they were paid in the first quarter of 2021. So that's January 1st through March 31st of, oh, I'm sorry, excuse me, 2022, not 2021. So the most recent completed quarter. So this will be like the total number of hours across all 3. So if one of them worked 100 hours, one of them worked 50, and one of them worked 100 as well, that would be 250. The number of overtime hours, the number of supplemental hours. So that goes back to hazard pay or a shift differential. If maybe you're paying somebody additional funding for working with a COVID patient or something like that, that's what we would want to capture here. That might be the same as the regular hours, but we do want to capture that. And then the amount of wages in sum associated with each of those types of hours. So total regular hours, total overtime hours, and total supplemental pay. So regular pay, overtime pay, and supplemental pay for that time period. And then any bonus amount. So this would be like a lump sum bonus if maybe they got an extra $1,000 for working through March or something like that, not necessarily associated with any hours, but just as a lump sum. So then this allocation of time is meant to show how much time they spend working on each type of service, but not what they're doing in that time frame. So let's say the psychologists generally split their time 50-50 across the 2 waivers in group counseling. We would have 50-50. But if maybe they work mostly on ABI and then actually all of them have 1 day a week dedicated to ABI LTC, we would enter 80 for ABI and 20 for ABI LTC. So that's just the amount of time spent on each service type more broadly, not necessarily what they're doing. And the other category is meant to say if they're working on something outside of a Medicaid waiver service that's covered under the rate study. So if they were working on, I don't know, maybe a state plan service that is not under the waiver, that might go under other or something like that. But so that's a little bit about the way this works. In terms of productivity, like what folks are doing at what time, we're not necessarily capturing that in this slide because we are, or in this tab, because we're relying on other sources to capture that type of time. So if somebody misses an appointment, we're capturing that. And if somebody spends some time entering notes or travel time, we do capture all of that. And we will be sure to be extremely transparent about the way that that is developed for you all, so that you understand where those numbers are coming from.
So then if they
Oh.
actually worked in a house as a direct support professional during some of that time, would that fall under other, since they're not doing counseling?
Well, I would assume if they were working in a, you're saying they're providing like a different
Yeah,
service.
I'm saying that all of my clinicians work houses as well. So where my counselor may treat in, counseling, very easy to do, but you know what? 2 days this week, there were 16 hours that they covered houses. So they were truly doing what would be traditional direct support professional type services. So am I pulling some of that out?
I guess.
Because that's where some of your bonus dollars are going to come into too. So, I mean, I don't know. I just know, again, everybody does everything right now, and it's not as cut and dry as to say, okay, I do 75% individual counseling, 25% group counseling.
Yeah, I guess I'm just, when you say covering houses, can you just tell me a little bit more about what you mean by that?
That means I'm a residential provider. I have 3 people in a house. I have to have one awake staff in that house, and that counselor is that awake staff, that they're there helping them with their day-to-day needs of that participant. They're not being a counselor, they're being a direct support staff, because I don't have anybody to work that shift. I had to pull them out of their counseling role and put them into that role.
Would you normally do that if we weren't in the context of COVID?
Not like I'm doing during COVID. I can't say that I would never have done that, but COVID in the last 2 years has really forced us to do that a lot.
And are you paying them the rate of a counselor or a direct service professional?
I'm paying them a rate of a counselor plus extra money to get them in there. So it's my cost is truly inflated, but it's not being picked up anywhere because, again, they're not a direct service professional. But most of them are getting paid something in addition to their regular cost. A lot of them are salaried with me. And so, we pay them over 40 hours extra. And then some are actually hourly, and we actually, again, bonus them to do, nobody wants to come in and work on Saturday evening shift. So if I have a counselor that would do that, I'm going to pay them to do that because somebody has to cover the house. So.
Just to piggyback off what Jane is saying and the question about would you normally do that during COVID or outside of COVID?
Yeah.
Yeah. So none of these wages that people are going to report, if you're wanting normally outside of COVID, I think we need to understand that these wages are inflated by COVID, what's being reported. So it's difficult to separate out, would you normally do that outside of COVID when the wages themselves are a result of COVID? Does that make sense?
Yes, and I think that is actually the easier part to tease out, is because likely the wages won't go down any. but you wouldn't hire a licensed practical counselor to be a personal support aide, for example, in the future.
I disagree with that. That was happening before COVID in a lot of places.
You
Just
were
because
hiring-
staffing was tight. No, providers were using whoever they could to help staff houses even before COVID.
Right.
It's obviously gotten way worse, but it was still an issue.
I'm not quite sure I'm following, because and let me repeat back what I heard. And you tell me if I'm hearing it inaccurately. Before COVID and the employment issues arose, let's say the minimum qualifications, I'm just using a CNA, for an aide within a residential setting. But providers were not hiring CNAs, but licensed practical counselors or psychologists as that support aide, and they were paying them a higher rate, even though they were getting reimbursed at a much lower rate.
No, I think providers are hiring direct support professionals to work in houses, but providers also have other employees with higher credentials who provide other services. And occasionally in a staffing crisis, you go to your other services and say, hey, clinician, I need you to go work in this house. And this was happening before COVID too, obviously to a much lesser extent.
I think to answer your question, I'm not hiring a counselor to go be a DSP.
Right,
No, absolutely
correct.
not. No.
That's not who we're recruiting to do that job, but to staff the house, that's the pool of resources we have to draw from.
So they're already employed, essentially.
Yes, correct.
Okay.
And I think part of the confusion is the category you have on the spreadsheet for direct support professional is much broader than the vernacular we use.
Okay,
Right?
so that actually,
I think the direct
so any of
support
this-
professional is that person who works in a day program, works in a residential setting, right? Primarily, maybe community supports, but when we hear that, I would never expect to see a drop down with a psychologist as a direct support professional, even though I could say that's what they do. And, we employ psychologists. I would never put that into that category. And I think that creates a confusion because what we're trying to do is staff the house, right? And we have someone who makes more than $12, $14, $15 an hour. But they're taken off from that, what they normally do to make sure the house is stuff, or in Jane's situation, supplement their salary as well. But I think the DSP language for when I hear that, it's that person who shows up and does the stuff that takes place in staff.
Yeah.
I just want to clarify that a psychologist is not an example of a direct support professional. The direct support professional was a separate example. So direct support professional is an option in the drop down, and we can change the example to reduce any confusion about that. But we're not saying that a psychologist is an example.
I understand. I think that's the confusion. I almost have a spreadsheet, just direct support professional, no drop down.
Well, so I think the purpose is for any of these services that we have listed in the services provided tab, you come over here to the direct service staff and you say, okay, who provides those services specifically? You choose who you employ to provide those. You select that person. So in some cases, depending on the service, it might be a direct support professional, but for other services, it's going to be a home health aide or a psychologist or a psychiatrist, because counseling has different requirements for provider qualifications than does other services.
Yeah.
So it depends on the service provided. You come here and you select, these are the services, these are the job title of the person providing that service. And then here is how much we're paying for it.
So Liz, I think one thing that would make it easier for folks filling this out is maybe don't start off with an example of a job title, but just leave, sample job description where it says on line 11. So I think that's throwing off folks that this section right here is all of the just direct service professionals.
Right, and you're actually trying to get all those direct staff, so that makes a
Right,
little bit
so-
more sense, so, but
yeah,
yeah, maybe
so-
take away the example there, that might
Right.
help.
Yeah.
And then, you know, in the instructions and in training, we need to be sure that, you know, folks recognize that when you go into services provided, so for every provider type, depending upon what services they're providing, they'll have the different options that says on allocation of time. And it's, you know, if you're only a residential provider, then you would only enter for you those services that are, you know, the staff that are in a residential setting.
So then that goes back to my internal case manager, not being captured in as a direct
Yep.
service staff,
So I think Pam had mentioned, and
Adding that?
I think we could do a drop down, Liz.
Okay,
And then we can do like case management internal or case management external.
that would be helpful.
And I just wanted to ask how obviously some of these folks are not paid hourly, some are paid by contract or salaried. Just clarify how you all wanted that reflected.
I think you could provide it in a lump sum under the total hours. But we would just want the portion of their salary for the quarter. So if they're paid on a yearly salary, that would, I guess, be divided by 4. But we do want it, and we explain this in the instructions, prorated, so that if let's say they started in February, we would not want their January, like we wouldn't want an entire quarter's worth of salary, since they only started in February.
And you're just wanting dollars by position, right? Because I'm thinking I'm going to do my direct support people, and then I'll probably hit it again because some are my employees and some are contracted labor, just so that you can see some of those cost differentials between the two, maybe.
And I don't
Exactly.
think it'd be an issue if they wanted to do as many as they want and if they have 4 of them that are at one salary, just adding 4 and then do the same description and do 3 at another salary. Would that be possible?
No, that's not an issue at all. That's great.
Okay.
And especially, we definitely only want them grouped if exactly what you're saying, like if you have some that are contractors and some that are employees, we would want those to be listed separately. And also if you have, maybe they're all employees, but they allocate their time differently. So, you know, that like employees A, B, and C, like these couple of people work mostly on ABI in this example, and only a little bit on ABI LTC, but these other 2 people work in a different ratio. And so you might want to separate them out because of that as well. So we will definitely encourage that. Whatever is the best way to separate that out is fine.
Yeah,
And
that's
Amy,
good.
for your question, Amy, we had talked about doing it by the year, but we thought that would deflate the wages because it seems like from the other rate studies that we've been doing, wages have been steadily increasing over the last year. And we figured it would make sense to capture the most recent, including all the recent new hires. So if you're having to bring in people at a higher wage than people have been there for 2 years, that would be evident.
Got it. I just wondered if maybe doing the entirety of fiscal year like 2021 and then Q1 in 2022 would maybe reflect that. I just want to simplify this if we can, because every quarter is a lot.
Yep, and that was kind of our tip as well, is to try to keep it as simple as possible, but get the most recent data. So we're able to capture the true costs, and again, not a deflated cost that averages out, the first of the year versus to today.
So
And
is there,
that's, sorry, Jane, go ahead.
well, I was going to ask about, it's actually the next tab on that additional question. As we've gone through COVID, some of those COVID, related costs have gone down, and
Yep.
even some of the bonuses, I guess, not the things on your sheet, you've got it covered because you're going to go backwards. But even some of our salary expenses are less because obviously we've had less cases in Q1 of 2022 than I've had, but when you look about my cost, so is there a way maybe we add something to the additional questions to talk about more about what COVID bonuses have we had to pay over the last 2 years? Because you're going to see a little bit of it, but I don't know if it's somewhere else that we get that total over the last 2 years, the dollars we've spent for that.
We don't have that over the last 2 years, but we do have for the last quarter, we do ask that question specifically related to benefits. So we ask any kind of other benefits that might get paid. And in our examples, we include those types of additional bonuses or things that are paid out that way, and what's the cost of, what's the cost of providing those benefits.
So do you feel like that's enough to capture that? I mean, I don't know. Again, I'm not exactly sure what these costs are going to, I'm sure that there's going to be used for lots of things. I just wonder if there's not, that there's not a need to capture all those dollars that have been spent in labor related to COVID over the last 2 years someplace. Again, maybe it's additional question. Maybe that's it. But maybe that's not needed.
Kind of along those lines, Jane, I think it's important to note that obviously we're talking about increased costs. We're trying to capture these increased costs.
Right.
But I do think it's important to remember that providers have had other sources of funding other than this rate to help pay for these increased costs, mainly in the form of PPP loans and the Provider Relief Fund. And I think it's important to recognize that those funds have kept providers afloat and be able to account for that money, so we don't just assume that it's their billables that's kept them afloat, or or COVID emergency COVID rates or things like that, because they have gotten these loans that have been really business saving for them.
And that's absolutely true for the smaller providers.
Is that information captured someplace? For the rate study?
No, we're not currently asking about other sources of funding.
I would ask about PPP loans and Provider Relief Fund payments, because I think that's an important factor to realize that, if a provider bills $500,000, but also got $500,000 in PPP relief and Provider Relief Fund relief that has allowed them to, and that's what allowed them to pay bonuses, et cetera. It's important to know that it was those additional federal funds that came down through COVID relief.
Yeah.
That was the trigger for paying for that, not the rate.
I don't know the I have to look. I don't know the PPP loans allow to pay bonuses. I know
It does. It does.
Does it? Okay.
Yeah.
I guess I don't think that the new rate is going to actively attempt to cover
but those are costs of doing business, right? And so I do think we need to not assume that the rates that are being billed have supported all of these costs that were likely paid for by Provider Relief Funds or the PPP loans, especially as it relates to bonuses.
Yeah, so I think we definitely want to capture the cost of doing business, as you said. And I think, so questions like, what additional benefits are you providing, that should capture those and in addition to the supplemental pay questions, should cover the amount of funding that is being spent regardless of the source of that funding, because these questions are not specific to a particular funding source.
Okay, I just want to make sure that, you know, we don't come out of this saying, oh, Kentucky pays its DSPs $15 an hour. The rates we have now support that, with
Right.
while knowing that we have all these other funding things that have led to that.
I just want to
Yeah.
I just want to point out that the rate development is an independent model, so it's not dependent on the current rates that are in play, and we're not. It's completely going to be a new independent model.
Right. So what Liz is saying is, if you're currently paying $15 an hour, regardless of any other fund sources that are being in there, and that's the wages that it takes to keep people employed, that'll be what starts off as our kind of our assumptions around, you know, what the new rates need to be. And it may be that they're still not high enough based on what we're seeing in other industries, surrounding areas, the BLS, all the other sources of data that we'll be looking at. So we're not starting from the old rate. We're starting at what it costs currently to deliver services, recognizing that with all the vacancies and everything else that you're experiencing, it may still not be enough. And I guess I also add on that if we, I guess, made the assumption that the PPP loans were allowing you to make supplemental payments and everything else, that, you know, outside of a pandemic, we don't want to be too generous with the rates. But you know, that's I think whenever we on this line right here, you know, the wages include any fund source that you have. If you get donations from the United Way, because you might be a nonprofit, if you have PPP loans in there, or just regular business loans that you had to take out to keep in business because of your censuses were low, or you had a decline in membership, that would all be captured in the total wages and all the total categories, I guess I should say.
I think, Jay, this is Steve Shannon. The concern is if that's captured in wages, we don't want, and folks on this call won't make this mistake. I don't think our partners at Medicaid will make this mistake, but will other policymakers interpret that, oh, look, the current array of rates support this because other revenue sources, are they included? Are they listed? At least some documentation of that. Because what happens is, the concern I have is someone's going to say, oh, you paid this in the existing SCL rate structure, that must be okay, right? Even though that's not the message we've given repeatedly, that's the concern I have. Does someone outside of this group see this? And, oh, wow, this must be working okay because they're still operating and they're paying this money. Therefore, the rate structure must be adequate. And we know it's not, and that's why we're doing this. We understand that, and we're glad you're here. However, that's my concern. Does someone else take this report and go someplace else with it where we don't want to go, that this must have been working for okay for folks? Does that make sense? And you can't control that. I think we'd feel better revenue streams, additional beyond the rate structure itself, supported this information, so at least it's available.
I just think it's a really easy question to ask, and people know exactly how much they've gotten in PPP loans and provider relief funds. It's just just 2 lines, and really, I think it's an important data point to collect.
I guess my thought is that it wouldn't necessarily, like, if the cost of providing wages is like $1,000, just, I know that's not the cost, I'm just saying, like, for provider like it doesn't, the source of that funding is not particularly relevant for the actual rate development, because we're building the rate models based on the cost of providing the services.
Yeah.
So like,
Yeah,
I just
so-
want to, the
Yeah.
purpose of collecting this information is to develop rates, and collecting that information like is not something that will allow us to develop a rate in a different way.
Yeah. So yeah, and Liz, I think, I mean, you're absolutely right on the approach that we're taking is independent of you know, all the other different fund sources that come into play right now. But I think what Steve and others are saying is they would like at least somewhere in this process that we reflect that we have some data point that says, look, you know, this is how we were able to maintain these wages. It's above and beyond what we got from Medicaid. And not that we necessarily will use that in the rates, because it's already infused within the salaries that are being paid out right now, right? So, and I'm going to ask Steve and Amy and others to kind of provide some input here, because I don't think it's easily discernible how much of the overtime, how much of the straight rate wages, whatever, can be attributed. But it's probably easier to say, you know, what was the organization's PPP loan for, either by the quarter or total for that year that we captured somewhere.
I would just put it on the other information sheet, just total of amounts you received in PPP loan. And
Okay.
it's important you include the provider relief fund from HHS, because several providers got several
Okay.
disbursements from that. And I
Steve,
just think it's a really easy data collection point.
Yeah, Steve, what do you think? Would that?
Yeah, I
capture
think
it?
that
You have to
that
turn-
helps. I just want
Okay.
something, so, because again, my concern is, you know, we get a final product and we're going to be married to that rate methodology for
Yep.
many years, right, Pam? Right?
I mean, we're
We're gonna
hoping,
do-
yes, that this is gonna
Yeah.
establish a base rate methodology that we can build on in the future. But, you know, we do have to at least have that base for CMS to, you know, for us to even continue and us to do anything with the rate.
And I don't want anyone, you know, and again, I've been here too long, truthfully. It's probably time for me to go home. But, you know, when people change, Pam goes somewhere else. She becomes commissioner, and the new Pam say, well, look, these rates were okay, right? That's always my concern, is as the players change, I want to be able to point to data that shows how we made it through this period.
Steve, I think that is very on point, and that is exactly what we want to do, so that this lives through. I mean, it's very well documented. It's very easy to understand, so that whoever comes after me, after, you know, Guidehouse, their work is done with us, that they can pick it up and understand, okay, this is what they did to get to this methodology.
And Pam, I think CMS would be interested to know, like, how those additional federal funds, especially related to the provider relief fund, was utilized by waiver providers in Kentucky. I mean, I think it might be an interesting data point for them to know about.
So let's scroll up a little bit, because up above we have it by quarter for the year. Is this how you think it would make the most sense to report the provider relief funds as well as the PPP and maybe an other category for something like United Way or donations?
I would just do provider relief fund and PPP fund, and you can just explain in the instructions, record the money in the quarter in which it was received. And for some people, that'll be a few different quarters, and for some people, that'll be one quarter.
I think if we're going to capture what they receive, that it would be beneficial to understand, you know, where they applied that. Because I don't think we can make the assumption across the board that every provider used those funds in the exact same way. So to get the most out of the data, if we're going to collect it, I think it would be beneficial to understand where the providers applied those funds. And just, I mean, and it could be general
Narrative?
General buckets, but yeah, or in a narrative, I think, but I think it's just, I think it would be valuable to collect what the funds were applied to.
And I would still say that it would be valuable to have the information of, you know, the cost of doing business during COVID. You know, again, the bonuses and things that we've had to pay over the last 2 years, again, because it's, you know, we're on the downside. So this last quarter, we haven't had as many positive cases. But when I'm, you know, I have, you know, 2 or 3 houses with a bunch of people in it, you know, that have COVID, that cost is jacks up, and you're going to see it under my PPE. But I think, again, on this tab, if there was the opportunity to again, capture maybe COVID bonuses, you know, throughout that entire time, 2 years. Again, maybe you don't need it for the rate methodology piece of it, but it's information for you to have. And it could tie into those loans as well.
Also, I would like to ask, so I know that, you know, Amy, Jane and Steve, thank you all for, you know, your interaction, your feedback, but you know, some of on our HCB side or some of our other services, is there any input that anybody else or any questions for, you know, the non-residential, the waivers that don't have that residential option, or maybe those types of services, if there's any, you know, additional feedback that you all would like to include. Steve, I know you touch over obviously into the PDS realm, but is there anything else there that anybody wants to bring up that we want to consider? I want to make sure we get, you know, global feedback, because this has been very valuable for us to make sure that the product that ultimately goes out is understandable and collects the data that we need.
Pam,
I
this
think,
is Jill
yeah,
from Kentucky River Ad. My question is you've mentioned you want to get operating costs, and the survey only pertains to personnel costs. Where are you going to capture those other costs associated with services such as space, utilities, office supplies? You know, all of those costs have went up greatly too.
So Jay, please keep me correct on this, but I believe that's part of the data we're going to use from the previous study, but applying inflation factors
Right.
to that to capture those increased costs, because, you know, we do realize utilities have went up. I mean, things there's been definitely an increased cost administratively too. So
Thank you.
Hey Pam, it's Amy. I put this in the chat, but I know this is something that affects all waivers. I think that providers will report that the productivity, or that, you know, unpaid time, or, you know, whatever we're calling it, has changed quite a bit since EVV. And I think we want to take a look at that.
I want to caution that though, because that is as much related to the product as it is to what the function of EVV should be, and limitations of the current product.
Okay, yeah, I understand that. I got you.
Okay.
Okay, so let me just make sure I captured what I heard on this. Is we will add a new column for CY20, and then we'll add a couple of new rows capturing the PPP loans, provider relief funds, and ask for a narrative description of how they were used.
yes, that seems fair, Jay.
Amy, Pam.
Yeah, I think that's perfect.
Yeah, that's what I
Okay.
had captured as well, Jay.
Do you think it makes a difference? I think we have it right now under the public health. Scroll up a little bit, Liz. Oh, I'm sorry, the other way. Okay. Well, no, I think we're fine with language, how we have it framed here. So maybe we'll do it at the end of protective equipment training. Like add like 12 or 13 right there.
Yeah, it also might make sense to have it as its own section, since that funding
Maybe.
applies to multiple tabs, and we don't necessarily want to give the impression that that funding only applies to training and PPE.
Okay.
You could just call it federal COVID relief if you, I mean, as the general heading.
One more quick question on this item for Amy, Steve, and others. As we're adding it in, could you give us a quick overview of some of the categories that you all did use it for? I think I heard overtime, just so I think it'll be easier to include some categories to make the data more usable rather than narratives, perhaps.
It could be used for, the categories differ between the two, but they're generally pretty similar. It could be used for anything directly related to the pandemic related to program support. So wages, bonuses, add-on payments, building modifications, equipment, technology, a bunch of different stuff like that. There's a list on it's in the PPP and the provider relief fund reporting. The IRS issued the list for PPP and HHS issued the acceptable uses list for the provider relief fund.
Okay, perfect. We'll look at those. Thank you.
And just note, providers are for PPP obviously required to apply for forgiveness, and for the provider relief fund from HHS, they're required to report to CMS on their uses of those funds.
Got it. Thank you for that context.
Anything else that you all wanted to look at or comment on specifically while I have this open, or that you'd like me to discuss? Since I know I didn't necessarily walk through each of the tabs, which is completely fine, but I want to give everyone the opportunity to ask.
I still just think in the instructions, we need to have a strong outline of what wages are to be reported on the wage tab, like what constitutes someone who provides direct care services. I realize we have other job titles than DSP, but you need to make clear if you don't want people to include your admin staff, things like that, just like as clear as possible with that kind of definition.
Yeah, so I guess that is one of our questions that we had in the slide deck for you all. But is that something like, is there a standard definition that you think would be common to across multiple providers? Or is that something you'd prefer we try to capture ourselves? Which we're happy to do, but we want to make sure that we're capturing, something most accurate for the providers.
This is Steve. I think it's along the lines of that person who is working, normally scheduled to work in a staff residence, group home, whatever it may be, may also work in a day program. I think those are, or maybe even provide respite, but it's not anyone who's directly contacting the person served, because then you get into your psychologist, your psychiatrist, whoever else it may be. But I think when I hear DSP, I'm really thinking of that core fundamental service that every provider has, regardless of what they're doing. And it's those folks who are working in homes and day programs and things along those lines. That makes sense, folks?
Yep.
I got
Steve,
you.
On this tab though, is it the title direct service staff that's throwing everybody for a loop?
Yeah.
Because I do put when we do, separate our staff, I do put my counselors and my nurses in direct staff is my person, as opposed to my non-direct staff. So I think maybe it's that direct staff, that term might be throwing some of us, because we would want to capture the dollars and things of those other positions because they are direct staff. They're just not direct service professionals. So I don't know if there's a way to change that.
Can
title.
we-
Yeah,
That's
I think
it.
we're on the same page, right, Jane?
Yeah, I
Can
think
we
we are.
just-
Steve.
We're
But I
gonna,
just want, yeah,
we're gonna change this direct service professional, so it's clear that we want all of your direct service staff, not just direct support professionals.
Yes.
So we do want any of those folks that you include in your direct service staff. But we also want to make sure that if somebody were to select a direct support professional as one of their direct service staff, that they would want to have an appropriate definition of what that is. Just like
Can
you
we
would want
just-
to know what sorry, go ahead.
Can we just define this as any, like, a direct service staff as anyone who provides a face-to-face service, outside of COVID restrictions? Because that captures case managers, DSPs, day training workers, behavior supports isn't included in this, but like community access, like all of those are face-to-face services. And then you can still have the job titles, obviously. Does that make sense?
Yeah, I think that works. I guess, yeah, I guess that makes sense to me. And then would you like us to eliminate direct support professional?
No, that's
No.
a job title. Keep that.
that is a job title.
Okay, I just wanted to make sure I was understanding. Thank you.
Job title, not a category, right?
Okay,
Anna, call extension 2134, please. Anna, 2134.
So I wonder if we have somebody that, and again, I'm that might not be in that category. Is there like an option for other or not?
we don't have that now, and that was why we don't. Let me actually go to the deck, because we wanted to spend some time talking about this.
Jane, that may be partially me. I hate other categories and we can avoid them.
So what do
I
we,
think
what
that
about our,
Well, I think as Liz is getting to the slide in the deck, I think we wanted you all to help us to try to figure out if we could capture as many of those in name as possible, just to try to avoid having the other. Of course, if we have to, we have to, but a lot of times people will just use that as it just ends up being a bucket, and it makes it a lot harder to really figure out what they put in that bucket, if that makes sense.
so the one position that I'm missing is my residential supervisor.
Okay.
Do they also?
Yeah.
I guess,
I
and they
agree with
also
that.
subsidize and support as a residential staff as well. So there'd be kind of a there would be a supervisor plus a direct care.
Yes.
Okay.
Yeah, I agree. And a lot of residential agencies have residential supervisors and individual house supervisors, and they can be paid differently. So I don't know how to account for that, but just keep that in mind.
So that again, residential and then a house supervisor.
Yeah, some have their organization set up so there's one residential supervisor that also provides direct care, and also supervisors for each house too.
And that's different than a residential supervisor, a house
It's-
supervisor.
It could be.
It could be. It's like a step down, I guess.
Okay. How are they just part of the, I'm going to call it the overhead, or how are they paid?
Again, mine are
I'd say-
paid as a direct staff. I mean, our financials, my RS is a direct cost for me, not an indirect.
Okay.
I'd say most are just paid at a higher hourly wage, but I hate to generalize without knowing for sure.
Kind of like a career ladder.
Yes. It's
Yeah.
very similar to a career ladder.
Okay, what else? We have a house supervisor, residential supervisor.
We're adding that additional case manager. I don't know if we're going to call it in-house or billable
Yep.
versus not billable case manager. We can decide on that later, but we are adding
Yeah.
that.
Well, what makes most sense for the group, since we have a little bit of time? Billable case manager, non-billable, or internal, external, or
We
I
use,
Client
think both
facing.
makes,
yeah, we use the term internal, but that's just what my agency does.
yeah, a lot of people use internal, but I think you just have to explain exactly what you mean really well in the instructions.
yeah,
So we want to capture the non-billable function. Right.
Yeah, exactly. I mean, and certainly like Steve and I can, you know, as trade associations, we can explain that, but not every provider belongs to our association.
Yeah,
So.
Jay, in the adult day side, those are called patient care coordinators. Those in-house
Okay.
folks that are case managers.
okay, patient care coordinator,
Right.
okay. Do others use that terminology too, or?
You could like make those things in the same line, like same title, like in-house case manager / patient care coordinator. I think people would understand that way. Meaning that they're, you know, relatively the same role. Because Kelly, you
Yeah.
all aren't billing for that either, right?
That's right. We don't bill for that service.
Right, okay. All right, so that would be a internal case manager / patient care coordinator. And instructions, we'll just kind of have a note that this would be an, you know, unbilled, currently unbilled, or something like that.
Yeah, that's perfect.
Anything else that we're missing that might go into normally in an other bucket that we can capture?
The only other thing that I would add is medical appointment coordinator. And I only add that because a lot of times these medical appointment coordinators are taking people to their medical appointments.
So wouldn't they be serving as like a driver in that capacity?
Yeah, but I don't know that that would be very intuitive to someone filling the survey out.
And
Or
medical
that would be easy, or if that would be easy to quantify.
I think people would see driver and think of van driver, not someone taking someone to medical.
Yeah.
So do you all think we should eliminate that one?
No, I think that's
Because I
important.
don't want them to think about non-emergency, Steve, to your point, non-emergency transportation.
Yeah, that's true, huh?
Hmm.
How would driver, I mean, if you saw a driver on this, what would you be thinking as you see that in your organization?
I would think someone whose sole job is to transport people from point A to point B, wherever those 2 points may be.
I think a van driver. But yeah, we need to make sure it's not non-emergency, because some folks do that, right, Pam?
Yeah, we do have, there's actually some providers that are also enrolled as NEMT, so.
Yeah.
And that's of
Pam-
course reimbursed in a totally different reimbursement stream.
Yeah.
And Pam, isn't mileage already accounted for in the past survey? Or are we
It
redoing
was
that?
Well, it was captured in some capacity, so I don't have all of that up in front of me, but yes, we did capture mileage. I think in both the delivery of direct services and as part of like incidental, like a residential, well, I guess we would be looking at the direct support professionals there, but yes, we did capture mileage. And that's something
think-
that can, you know, obviously the mileage rate is something that's federally established. Now, depending on if you choose to pay a different rate than that.
I think it's fine to leave driver, but in the definition of that service, you just need to make really clear what you are and are not talking about. And also understand that driver is going to be something that people do in their role as a direct support professional or a medical appointment coordinator or sometimes a nurse, and that providers may not have the data available to quantify how many hours they drove in their acting in their role as a medical appointment coordinator or a DSP or something else, a home health aide.
Okay. So I think, and while you're thinking about other categories that we might add, let me add a qualifier for the driver. The driver might be somebody who transports to point A to point B, but it wouldn't necessarily, or in this context, it wouldn't participate in the doctor visit with the individual. If we're using that as an example, where medical patient coordinator would both transport but participate in the consult, we'll call it.
Yes, but I mean, every organization does it different. Like some organizations may not actually employ a dedicated medical appointment coordinator. A lot do, but some just use a DSP to do that, who also acts as driver and sits in on the doctor's appointment. So there are different. I know. I'm just explaining there are different ways to capture the data.
Right, and I think though we want to be careful because in the end the intent is what these. So we want to capture the data in a way that we understand the costs that providers are incurring, but we also don't want to create a bunch of, so for example, there may be somebody that has, they've hired this medical appointment specialist. I think that's what you said, but that really is a service that should be part of maybe the case manager or part of the direct support professional. So we want to make sure we capture the cost of the task that they should be doing as part of their, as part of what's expected of them, that we don't create these other categories for things that don't necessarily exist within the waiver. So like, for example, I couldn't go to CMS and say, okay, we're now going to have this, we're going to show this information for this medical appointment coordinator, because that's not a service that exists within the waiver. So I just want to make sure whatever we do it in the context that we capture it where it either should live now, or that we capture, maybe we have a category that has not, that we need to have another discussion because we've identified a gap in a service that we need to look at. Is there, when we redo the waivers, is there another service that we need to add, if that makes sense?
Well, I think that's largely done by residential providers, and it's a necessary service, just like we talked about this in-house care coordinator that everybody seems to mostly do. And maybe you can just include something like that in care coordinator. I was just trying to explain that the lines with these job types are not clear cut. They get blurred a lot, especially when we're talking about residential services.
And so I guess I would like to hear Kelly or I don't seem to have my list up right now. So, or Evan, I know you're on. And so some of the providers in waivers that do not provide residential, what is your input, or what do you see as additional things that may need to be captured outside of, I just want to make sure we get a holistic view of this, because, while we have a lot of individuals receiving residential, we have a larger percent that are not. So I want to make sure we cover everyone's needs and capture the data accurately from everyone.
And this, Kelly, I think it does a really good job at capturing the cost. associated with it. I'd like to catch that with, as this thing progresses and moves on, as we get more permanent in the thinking about it. I'll send any comments that I might have, obviously, before the 31st, but I think it does a good job right now capturing that.
Thank you.
Yeah, I'd agree with that too, Pam. I think we're moving in the right direction.
Thanks, Evan.
Okay, so let's go to the next slide. I think we have some notes on the ones to add, and then we have just a few minutes left.
Yeah, so I think we quickly wanted to talk about the communications plan. Pam, did you want to take this slide?
Yeah, I'll take this slide. So we are going to have technical assistance provided in a couple of different methods. And so you'll see on the screen, there's the 2 different mailboxes for rate study questions. So we asked for survey specific or technical questions for you to use the KY HCBS rate study at guidehouse.com. You always still can email our general rate study email box, which is chfs.ratestudyworkgroup@ky.gov. If one gets sent to, one of the boxes and it needs to go to the other, there's a whole process in place that we make sure that it gets to the right individuals. So don't worry if you accidentally, you're not sure, or maybe you sent one and thought, oh, I sent it to the wrong box. It will get to the correct individuals. We are developing and will post an FAQ document on our cost survey website, which I believe Kelly has posted the link to in the chat. And then we will be having the training, but we are also going to record that training, and it will be posted on the survey website. So that will allow individuals to come back and rewatch if they have questions, or it's impossible to meet everyone's schedules. So that will allow individuals to go back and see the same training that everybody else received if they have to watch it at a later time. So here is what happened, or where we are with communication. So you can see that on 3/24, we did the pre-communication. You received the announcement and the survey release. And then we have the dates that are going to be happening over basically the next month. So the next thing that you'll receive is that the announcement of the survey release with the training dates, and then followed by the survey trainings. And then we have set up to do weekly reminders to complete the survey with a reference to the FAQs and the inbox email address, as well as the survey deadline right now is 5/6. I will also add, when the communication went out of survey release and training dates, there was a link, and Kelly, you may have to jump in here if I get this wrong. There was a link in that survey that asked for you all to just do a quick, if you could go to that link and quickly let us know who is the best individual within your agency to receive the survey. So we're asking that of all the other providers. So if you can kind of communicate that to your peers, that will just make sure that we target the survey to the right person, and that it doesn't maybe sit in someone's inbox and maybe they aren't sure exactly where to send it, or maybe they're out on vacation. It just makes sure that we have timely notification of the survey and get it in the hands of the right people.
So just to piggyback on that, Pam, I mean, we'll continue to send it out through our regular provider list, but the targeted list will help, as Pam said, just make sure it really does get to the direct people, but we'll continue to disseminate it widely too. So just know that self-reported list is not like the only way it'll go out.
Okay, we can go to the next slide. So our upcoming timelines. We need the comments back from the work group by 3/31 in order to have time to edit the survey and release it by 4/7. And then providers will have a month to respond, which aligns with the last time. And we've seen, Guidehouse has seen this timeline to be really successful. in other states. We will be, keeping our pulse on the number of responses that we're getting, and may also reach out to you all to, remind your peers to respond if they have not already. Kelly, the next slide. So our topics for our upcoming meetings. So as you know, in this meeting, we talked about the survey and our communication approach. In April, we will be discussing the model assumptions. So reviewing and updating the key model assumptions from the previous rate study, as well as that's going to include program support cost factors, administrative overhead, productivity, and staff patterns. In May, we'll review those survey results. June, we'll follow up with more model assumption discussion, as well as in July. And then we're targeted in August to share proposed rate models and fiscal impact. So then any other questions or feedback? And I've got my screen. I can't see the chat at this moment, the way that we've got the screen. So I don't know, anybody let me know if there's any other questions in chat that we need to address.
One thing I saw in the chat that Amy asked where everyone should send comments. I responded in the chat, but in case folks didn't see it, if you could send it to the KY HCBS rate study at guidehouse.com, which is the Guidehouse email address, that would be great.
All right, so we went just a couple minutes over. Thank you all so much for your participation today. We look forward to receiving your additional comments back in the next couple of days. And honestly, I'm excited to get the survey distributed and start getting some feedback so that we can make progress in this area. So thank you all for attending and have a great rest of the week.
Thank you, Pam.
Thank you all.
Thank
Appreciate
you.
it.
Thanks, everybody.